My guest today on the Deep Sea Journey podcast is Dr. Tim Matatov of Southwest Breast and Aesthetic in the beautiful Scottsdale area in Phoenix, Arizona. Dr. Matatov is a microsurgically trained, board-certified breast reconstruction surgeon who performs procedures that include implant reconstruction, a number of autologous breast reconstructions, and autologous meaning using the patient's own tissue, nipple reconstruction, and a variety of other breast reconstruction procedures. I've had the pleasure of knowing Dr. Matatov for a few years and have watched his practice grow. I've heard from patients who are very pleased they made the choice to go to Southwest Breast and Aesthetics. And most recently, I had the opportunity to visit the practice in March of this year, 2023. And it was during that visit that I met his other surgical team members, that is Dr. Joseph Zachary and Dr. Matthew Mino, and other members of the Southwest Breast and Aesthetic staff who care for breast cancer patients, those affected by breast cancer, and going to Southwest Breast and Aesthetics for breast reconstruction surgery. So they take care of those patients well during their personal journey. How's it going, Dr. Matatov?
It's going great. Today's a beautiful day in the sunny Phoenix, Scottsdale area. Surprisingly have a midday sort of morning and afternoon off. So it's going great.
Are you going to go
Get to drop my
golfing?
kids off. I already got coffee and I got to drop my kids off. Once in the blue moon, I get to take them. Super exciting.
That's cool. That's the cool dad part, right? When you have those
Yeah.
little time off to drop the kids off. Well, you've already had your coffee, so I miss my avocado toast and coffee at our favorite coffee shop in Scottsdale.
Oh, yes, yes.
Yeah, did you go there this morning?
I did not, but I'm gonna try to make it an afternoon. My son has a Cinco de Mayo party at his school, so I will make a detour prior to coming there.
That's right. We're recording and it's Cinco de Mayo.
Yeah,
That's
yes,
a big celebration in
it
Phoenix, I'm
is.
sure. Yeah.
Oh yeah, he's been excited. So
Oh, that's cool. Are they doing the piñata and all that today or
yes, they are. Yes,
oh,
they
fun.
are. It is
Fun.
good. Yeah, he's been talking about it all week. It's
I
just
bet they have. I bet
yeah,
so. Well, I remember sitting out in that coffee shop. We solved a lot of the major life's problems that day, didn't
we
we?
did. We
Yeah.
did.
Yeah.
It was
Well,
glorious.
I know it was, oh gosh, it was such a beautiful day. So our topic today, and I'm so glad that you joined me. I really appreciate you spending your morning with me today, is achieving symmetry and also understanding fat grafting in breast reconstruction. So I guess the first question I want to ask you, Dr. Matatov, is why is mastopexy, which is a breast lift, and I'll let you dive into that a little bit more. Why is a mastopexy sometimes needed in the setting of nipple-sparing breast reconstruction? I've had a lot of questions about both of these topics lately, and so thanks for helping us out with this education because patients are very curious.
Of course. Thank you for having me, Terry.
Yeah.
Well, mastopexy or a breast lift procedures are performed for reconstructive purposes as well as cosmetic purposes, so aesthetic surgery. So whether the patient has a single breast reconstruction with their own tissue, an implant, or oncoplastic reconstruction, sometimes the contralateral breast will not match the reconstructive breast.
Mm-hmm.
So besides the obvious cosmetic issues that you would see of a symmetry, there are also some functional issues like wearing a bra. Sometimes you can't even find a bra that will cup one breast and not the other breast, or the bra
Yeah.
sliding off. Or the other breast, a reduction or a mastopexy or a breast reduction or breast mastopexy lift roughly the same operations, and a reduction, you take the skin and the gland itself, and the mastopexy you also mainly removing the skin and might remove some gland tissue. So those are the main reasons that people perform a balancing procedure or a symmetry procedure in the setting of a single breast reconstruction.
Okay.
So those are the main reasons that people will do that, just not achieved, not having symmetry, as well as some of the functional, mainly wardrobe issues, or even the psychological issues. When patients are so far off, one breast looks, they're not even sisters. They're not, nothing's close to being the same. You want some sort of a reasonable symmetry. But most patients that will get breast cancer will be, somewhere between 30s and 50s. And in that situation, there's some changes that occurred to the non-cancer breast that sometimes sometimes patient may want to address those for symmetry reasons.
Yeah, I think it really comes down to comfort and quality of life issue, because I have heard women say finding a bra is very difficult sometimes. Just that inframammary fold, taking care of that, the excess tissue, and most women wear a bra every day, and the
Right.
rubbing and the discomfort and all of that, I personally consider that a quality of life issue, and
Absolutely.
yeah, so that.
Absolutely. But even if you don't, even if you do wear a bra and sometimes it's visible through clothing, it can be that far off. So obviously finding not just a bra, but in general, a wardrobe is challenging. And you'll see women wear these loose t-shirts, or it's kind of loose blouse. So you can camouflage this better. Now it's doable, but in general, most people will revert to surgical procedures to make them even, and most of the time it's for functional reasons.
Yes, the functional and also the psychological reasons. It's not just being able to wear clothing. Like you said, some have to wear looser clothing. But when women have no clothing on, and they're either with their partner or they're looking at themselves in the mirror, that is psychological issues, trauma that they have to deal
Right.
with when the breasts are not symmetrical. So, right.
Yeah, even just looking at themselves in the mirror just gives you that reminder of the trauma that you've gone through, versus just looking at yourself in the mirror and like being happy with your body, or content, and not having to give yourselves reasons why you have to look that way. So I think the psychological component is huge, and it's for majority of the time that's what it's for as well. Like, it's not for anybody else but the patient.
Oh, 100%. Well said. So can you tell us about the different types? I have read in research articles I've, seen at conferences, there are various types of mastopexy procedures used. I think they have names. I've heard, some of them have names. And there is different scar placement, because like you mentioned previously, sometimes skin is removed, sometimes skin and tissue is glandular tissue is removed. Can you tell us a little bit about that, Dr. Matatov?
Sure. We think of a mastopexy as a breast lift. It's not just a nipple repositioning procedure, because there are some nipple repositioning procedures that exist, and maybe that's what most people that's what some people need. In general, that's not the case, but we can start from the minimal nipple movement, which we call as a crescent mastopexy, where just the top of the areola has sort of this crescent removed, and the areola gets to move up. It's not a mastopexy, it's a nipple repositioning procedure, because in some patients you can have a nipple that's just a little bit off, but in general that's reverted to for a cosmetic procedure.
I see.
Then next one in line would be the circumareolar mastopexy, or donut mastopexy. It's when you have a circle within a circle. So that also mainly is done to reposition the areola. It does not do as much as you would hope for as far as the breast lift, like lifting the entire gland upwards.
I see.
It does reposition the nipple. It has its drawbacks. The reason I don't like it, of course, depends on who does it and how much experience people have with that. But the
Of course.
drawbacks that I've seen in my patients, it flattens out the breast because you're kind of pushing everything towards the middle, and you creating this ring. And you do have to use, in most situations, a permanent stitch that you go all the way around, so this nipple doesn't open back up, because you have an external incision around the nipple and then internal diameter of the nipple. So you're trying to then bring everything back to the center to make that incision smaller, and keeping the scars within the areola. So try to minimize the scarring. I've just not had great success with that surgery in most patients. Now, I've used it when I'm trying to move the nipple or the gland just a little bit, but in general, that's not the procedure that I perform, or at least our practice performs, for a breast lift. A little bit more movement in the next procedure would be what's called a lollipop. It's an incision around the areola, and the incision goes from the areola down to the fold, or a circumvertical, we'll call it as well. And that's a really good operation where you can move the entire gland, as well as the nipple in the correct procedure to match the contralateral breast that already had a mastectomy or some sort of an oncoplastic reconstruction. That avoids an incision in the fold.
Okay.
And also the vertical component allows you to move and reduce the skin in the horizontal dimension.
Yeah.
So somebody who has, let's say, a wider breast, you can bring that breast a little bit, make it a little bit more narrow. And also, as you gather the tissue together, it lifts your breast up and moves it forward. And also, there's that lollipop component, the circular component, where we move the nipple, that allows us to move the nipple. That to me is a true breast lift procedure, because you are moving the gland as well as the nipple.
Yeah.
Most people will have, there's several reasons for ptosis. There can be ptosis of the nipple, or there can be ptosis of the gland. And a lot of patients have both. So by just moving the nipple, you're not really treating the what's called glandular ptosis, since gravity gets us all eventually. The breast is right. The breast slides off the chest wall, going down towards the floor. And it's just kind of how everything moves in that direction. And that incision allows us to move the not just incision, but that approach allows us to move the breast higher. So you have skin procedures, which we call them skin incisions, that treats the skin envelope, and then there's a glandular incision. So when you do a breast lift, you have to do both. You treat the gland with a glandular procedure, whatever that may be, or you treat the skin, and that to me moves the breast in the direction you want to go.
All depending on the size, location of the patient's breast. Yes, and ptotic or breast. The term ptosis meaning, droopy. Kind of a droopy downward motion. Yes, wasn't there John Mayer's song "Gravity is Working Against Me"?
Yes.
So that's part of your symmetry, that's okay.
Correct.
Go ahead.
That procedure limits the movement. There's probably, you have about 3 to 5 centimeters, or let's say inch, maybe 2 inches of a movement that you can get with that kind of incision. Not everyone's a candidate for that operation. And then the next one in line, which is it can treat any breast ptosis or droopiness, is called a wise pattern mastopexy or breast reduction, and that's what common name for patients call it anchor scar.
Yeah,
so
I hear a lot of breast surgeons using that term.
Correct. So you'll
Yeah.
have a scar around the areola.
Mm-hmm.
That scar allows us to reposition the areola where we want it to go, nipple areola complex. Then you have the scar from the areola down to the fold. Again, allows us to reduce the breast or reduce or lift the breast in this dimension.
Mm-hmm.
And then you have an incision in the fold that lets us work out the excess, as well as the reduction in the vertical dimension.
Mm-hmm.
So some patients will require both, and in general, a wide pattern mastopexy in patients that are applicable in patients that have very loose, stretchy skin with a good bit of stretch marks, usually though after weight loss or breastfeeding,
Mm-hmm.
or their breast size is larger and needs a more aggressive reduction or a breast lift. And depending what the other side looks like, also depends on what will be the treatment. Sometimes the patients will get radiation to the mastectomy side or an oncoplastic side, which oncoplastic patients should always get radiation in general to the cancer side, since we're not removing the gland. And there's that prediction of what is going to happen with this radiated breast and how much do you need to move up. And in general, there's some atrophy that occurs to that breast. So when you do that lift on the contralateral breast, the non-cancer breast, you kind of have to predict the future, also being well aware that you cannot predict the future. Everybody's different, and everyone's breast will move in different ways. So
what do you do? Overcompensate a little bit on the
correct.
non-radiated? Yes.
Correct.
Radiation, the gift that keeps on giving, I always say, and it is hard to predict.
Correct. Some patients will have very minimal changes from radiation. Some have moderate, and some have significant changes. So when we lift the breast or reduce the breast in general, I overcorrect with the lift it just a little bit. And in the reduction, I try to make that breast just a bit smaller than the cancer breast, knowing that the cancer breast is most likely going to atrophy. And so hopefully I can achieve reasonable symmetry. And I've used that word before today, but reasonable symmetry, I mean, we have to also understand that patients were never symmetric. No one's breast is symmetric. I've never seen it.
No.
So
Not even before breast cancer.
Correct. A reasonable symmetry, we need to assume that as long as you're within about a half a cup from the from side to side different, to me that's a reasonable symmetry. A cup can also be depending on the patient, but a cup now you're getting into different bra sizes potentially, so may or may not consider that reasonable, but it should never be the same. You will never have, even if you somehow get lucky and you have this reconstruction that's symmetric, over time the changes, forces that you apply to that breast will make you asymmetric. And the common questions that patients ask are, well, why am I slightly off here? Why am I slightly off there? Well, it may not just be the breast. So if you're a right hand dominant individual, your pectoralis major muscle will be more robust. It'll be a bulkier and bigger muscle. Your chest wall may be slightly different because of that. So just as I'm treating the breast, there's still other underlying structural changes that I cannot change. So that also goes into what causes asymmetry. And some patients, I just tell them, look, your right breast was the non-cancer breast, and that's the breast that we have. It looks like slightly smaller, slightly bigger. It all depends. I may just tell the patient the left breast and exercise the left breast pectoralis major muscle only to make them a little bit more even, because you can change some of these things without having to do surgery in some individuals. That's not the case. It's an adjunct. That's not always the case. It's an adjunct, and we need to consider that. Not everything has to be fixed with surgery. And if you think about this global picture, is that you're treating the entire individual and not just the breast, then you can have, first of all, reasonable expectations with a patient, but also achieve some sort of a symmetry without sometimes having to do more aggressive procedures.
This is such good information, I think, for patients to hear, to bring up at their consult, especially about in the presence of radiation.
Right.
Great information for them to bring up.
Mm-hmm.
they are sisters, not twins.
That's right.
Yes, I hear that phrase often. And I really also like you mentioning, the managing expectations, because
Right.
it's so odd to me. I've said this in other podcasts, other YouTube videos. It's not odd to me. I hear it a lot. I'm guilty of it myself. I was not a person who ever would have walked into a plastic surgeon's office. That's just me. But I did. And then once I did, I hear this from other patients too. I think we become a little hypersensitive to looking at
Absolutely.
ourselves after the surgery. And why wouldn't you after you've been,
Absolutely.
worked on? So really great explanation. Okay, we're gonna segue to this other topic. Patients are so curious about how fat grafting not only works, but because they're frequently told, only a percentage of that fat will stay. So when I'm talking about fat grafting, just for the listeners, this is phase 2 or stage 2 of your breast reconstruction. So, and we're not just talking about deep flap here. Fat grafting can be done either with deep flap or implant reconstruction. It's they call it liquid gold for a reason. So I'm thinking here, I hadn't read this into the conversation, Dr. Matatov, but I want the listeners to know that this is what we're talking about on this topic now of fat grafting. But they're so curious, like, how does that fat glom on? I use the word glom on a lot. Does it have a blood source? Once it's put into your body with that cannula, what kind of cannula is used? All of those things. They're so curious about that. How does it stick in there, and why does some of it just go away? Take
Magic.
it over. That's my
Oh,
back end information.
okay. Well, I'm going to start off and say a lot of these techniques and as well as percentages and how it all works is for majority part of theoretical. So we don't have any hard proof that one technique works better than the other. We also don't have any proof that one device that you use the fat grafting works better than the other. There are some studies. There are some studies that are available. They are peer reviewed. They're not studies that are randomized and controlled to degree to where you can honestly say this is a better way to do that, or this retains more fat than some other way. But it is still a very powerful tool. It does work. Again, here comes the patient expectation management is the most important thing to me here, because I cannot predict, and no one else on this planet can predict how much of that fat that you're going to place will stay. So I start off the conversation with the patient at first that this, depending on the degree of a deformity, I will say this is going to take more than one surgery. It's very challenging to do this in one operation. And I also have to tell patients that your first week or second week, you're going to love it because you're swollen. There's some swelling that occurs with the procedure. There's also the fat that's currently in there. It doesn't mean it's alive, but it's in there, that's occupying the space. It's giving you this projection of fixed your deformity. And since we're using a tiny cannula, we inject things into the tissue, so we do cause trauma, and that's the inflammation. And there's a little bit of bleeding, just bruising. I'm sure everyone had an IV. You take it out, and that IV or a blood draw has a little staining at the skin. Well, that's a little bit of blood there as well. So that contributes to this nice volume. Patients love the appearance of their breast. And as the time starts to go further from the initial surgery, they start to get disappointment. And this is where the physician needs to manage the expectation. And they tell them, look, you're going to love me your first 2 weeks. And then you're going to say, wow, where did you do with my fat? Where is that all going? And toward probably 6 months, 3 months, 6 months to a year, and like, oh, this guy doesn't know what he's doing, stuff like that. So it's normal, but the point is to keep a patient's expectation. And it's not possible to fix a large deformity in one operation, and sometimes in a small deformity it's not possible to fix in one operation. Radiation is a very different ballgame now. The fat just takes very different in that situation. So radiation is it's ionized, so it does steal an electron from every atom in that part of the body where the beam has gone through. So it's permanently changed that tissue.
Wow. You're
And
getting
the whole
geeky on
point,
us now.
yeah, the whole point is to decrease the amount of blood flow and cause some fibrosis in that area. So decreases your chance of recurrence, and if it does recur, hopefully contains it or it doesn't allow it to spread. Because cancer needs blood flow, lots of blood flow. It needs nutrients. It's like a growing baby. It needs a lot of nutrients. It consumes a lot of energy. So if you limit that blood flow, it helps. But also when you try to fat graft, you're already limited in blood flow. So your take is not general, doesn't take as well.
Yeah.
Now it still works
Yep.
if you manage expectations and prepare patients for potentially 2, 3, 4, 5 operations. It all depends.
Mm-hmm.
So I also tell patients it's not possible to lose all the fat, and it's also not possible to have all the fat take.
Mm-hmm.
There's always something that takes. It may just not be noticeable right away.
Yeah.
So there are many ways to do fat grafting, many devices. I've tried almost all of them. And I do think there's I've also read the studies that are available, also read the techniques that people have done. In my experience, what I've read, I do think the most important technique in fat grafting is what we call placing small aliquots, meaning that you are placing very little fat for the tissue where you inject into. So if you give too much in one sitting, then the blood flow will not reach the center where you're trying to place it, and patients get these little firm nodules or oil cysts. And in cancer patients, and it's scary. They're like, oh my God, my cancer's back, and I need a biopsy, or I need to do this. So people do these high volume. Oh yeah, people that do high volume fat grafting, or at least powered fat grafting, where they revert, instead of placing this manually with a syringe, they'll attach it to the power source and just start to like dump those things. It's mainly came from buttock augmentations in women that would like to have their buttock enhanced. And that's a little bit of a different approach, but the concept is the same. So I think placing large boluses or large volume in one space almost guarantees that you will have a lot of fat necrosis.
Yeah.
And you will have those nodules that you feel. So to me, that's one of the most important things, is to place small aliquots to be successful. Also, you cannot with the way we also think about the breast or the tissue with fat grafting is a recipient bed. Mm-hmm. And then you have a donor tissue, whatever that is, skin graft or fat graft or fascia graft, whatever that you're using, a bone graft. But you have a recipient bed and you have a donor. So you cannot expect, let's say theoretically a breast has 1,000 cells. We cannot expect to place 2,000 cells of fat and expect that to live. There's just no way.
It's like overfilling a sponge. You can put so much water in a sponge and then it's done.
Correct.
Yeah.
And then the more fat you place, the more competition you're causing between the fat cells. So once you place the fat cells or skin graft or bone graft, these concepts are the same. Once you place that in, it automatically triggers the body to start promoting vascular growth. There are hormones that our body, the whole thing functions based on signal and pathways. So the body starts to figure out a way, okay, now I have these things, I have something that doesn't have blood flow, I need to figure out how to promote blood flow so this can survive. It's a normal response to trauma. So we just manipulate that process.
Yeah.
And as soon as you put those fat cells, the body tries to figure out, including the fat cells that are there, how to survive, how to respond, and how to promote vascular growth. So if you overplace, you put too many fat cells, now they're competing for this limited amount of blood flow.
Mm-hmm.
So you're more likely to have more necrosis
Right.
of fat cells. Okay. Again, this is all theoretical. We don't have anything hard proof to say this is exactly how this works. But in general, that's kind of the concept of how we determine, amount of fat grafting, amount of skin grafting, how thick the skin graft is. The same thing for bone, how much of a length we have, a length of bone. It's also all plastic surgery. How much of a bone graft can you put? What is the distance of a defect? So too big of a defect won't work, too small of a defect more likely to work. So same thing here. So if you over-inject the recipient bed, if you oversaturate it, you're not going to have a good success. Okay.
Yeah.
So, and that is where these multiple procedures come in. It is purely like layering a cake. You have to come back and do it over again. So this is how I approach this. I use a small syringe. So the smaller the syringe to me, the less pressure I'm going to apply, the less effort I have to do, less power I have to use to inject that syringe, and allows me to place these small aliquots. And it really is multiple passes. I mean, sometimes a breast will require like 1,000 passes, of gentle placement of this fat everywhere to have a better take. And then as soon as I lose resistance, I use a cannula. It's more of a flat cannula. It allows me to place a fat layer that's a little bit more flat, so I can have better take. So the bigger the diameter of your fat grafting disposition or a placement, the more likely you're going to have central necrosis. It's pretty unlikely that the blood flow is going to get down to the middle in time before the fat cells die. And we have about 24 to 48 hours, maybe 72 hours before the fat cell starts to die. The good thing about fat cells is they're low metabolic cells.
Okay.
They're mainly battery storage or fat storage, right? So they're there to store energy. They're also there to store energy to make hormones. So they're in general like a muscle or brain or solid organ. They are very low metabolic, and so is the skin. That's why the skin grafts work very well. So they have that time where you can have a better take versus, let's say, a muscle. Muscle has about 4 to 6 hours before there's irreversible damage. Because their muscle is so active, it requires a lot of energy, like therefore blood flow. It's susceptible to necrosis a lot faster than, say, fat cells. Fat cells do not require much because they're a storage facility, but there's still time limit. So if you don't have that vascularity, or at least some sort of this body fluid that has nutrients, doesn't get in the center, you're more likely to have this necrosis. And some of the studies, again, theoretical studies, says that anything more than 0.4 centimeters or 4 millimeters in diameter is going to have a hard time getting down to the center, and you will lose some of that central fat. Yeah. So that's the cannula I use, and I make these small passes, and I try to estimate how much fat I can place. So once the fat is placed, then I tell patients, try not to disturb the fat, meaning that don't do anything that moves the breast up and down in any direction. Don't apply pressure on them. We want to keep them stable, so nothing disrupts that blood flow that's trying to form, or what's technically a shear force. Again, I'm keep referring to skin grafts because it's a very common procedure to be done, but you don't want to move the skin graft. Once you place it, the thing that can kill your skin graft would be some kind of fluid underneath the skin graft, or shear force or infection, obviously. Same thing with fat grafting. Correct, disruption. Yeah. So same thing with fat grafting. We want to not minimize movement. Then I tell them by 2 weeks, try not to move around, move the breast around to where they're moving a lot or applying pressure. So, and then the process of vascularization occurs during this whole time, and then whatever fat acquired the blood flow and was able to survive, that fat survives and stays there permanently.
Okay.
It does not move around. It doesn't have the freedom like, let's say, an implant. It's just like a flap. Once you put the flap in, the flap incorporates in the surrounding tissue. And the scar that's formed, you also have blood vessels that come now from the flap into the surrounding tissue, not just that one blood vessel that you've connected. It's in the same way. It doesn't go anywhere. What people
All
mean, I think,
starts integrating.
correct.
Yeah.
Correct. What people mean, like, oh, my fat has gone away or my fat has moved, does it move? I think what they mean is that they've lost it. It atrophied. It's gone away. You've lost volume. It doesn't, whatever survives, once it survives, it stays there and it functions just like a fat cell does. And at that point, now it is the new graftable bed.
Thus the multiple procedures and the layering.
Thus the multiple, correct. So
Yes.
let's say we go back to that 1,000 cells in the breast. So let's say I put with 1,000 cells and we added another 500. So now we have 1,500 cells. So the second go around, I'm able to place more fat and expecting more of that to live because I have a bigger graftable bed. And you keep adding until you the desired result. And it's really hard to predict how many surgeries will that take and how much fat will survive. The literature says somewhere between 10 to 80%. Okay, that's such a wide range.
Yes.
And I tell patients 50% is a good number. In the radiated bed, I say probably lower than that. You're closer to maybe 20-30%. Also, in a patient that does not have a big graftable bed, I can only put so little, so the impact is very little. So therefore, even though the percentage is, let's say, whatever it is, 20% or 50%, you won't see as much of an impact because I was only able to place so little.
So patient specific.
Correct. And sometimes I see these people that will get fat grafting to around their implants and will have like 200 cc's injected. I'm like, where is all this going? How are you able to place that much in that tissue since you only have a little rim of skin and subcutaneous fat that can receive that fat. So the implant is not a graftable bed. So by over injecting, you tend to lose more. So if there's no resistance to me, if there's no resistance when I'm trying to pass this cannula, if it goes very smooth like butter, I know I've already injected fat in that area. So therefore I do not inject anymore because I'm not going to get anywhere. I'm giving this patient a false perception of volume for the first 2 weeks. So I like, okay, I pull out and I go in the direction until I start to feel resistance. And as soon as I feel resistance, like, okay, most likely I did not inject there. So then I inject at that point. And that's kind of how I build on fat grafting. And in the flap case, your whole breast, the whole flap is a graftable bed. So in that situation, you can put way more fat and expect that to survive a little bit better, or at least more of it. Not necessarily, the percentage may not change, but you haven't more survived because you've placed more in the appropriate graftable bed.
Right. I like that. The appropriate graftable bed. Yes. Yes. So smooth like butter. I like that term. And I think that we should roll into this conversation quickly here, Dr. Matatov, that, what you just talked about seemed like, whoa, lots of stuff going on there. But fat grafting is generally a day surgery. No, it was for me.
It is outpatient surgery.
Yes. So I want patients to know this, even though this seems, everything you said today was in so much detail. And I believe in most settings. Okay, I have to preclude this by saying if this is stage 2, phase 2, whatever you want to call it, a lot of times there's scar revision and there might be some further incisions that have to be taped up. But in terms of the cannulas, there's really no large incisions there. Mine were covered with a steri strip. I know
Correct.
that it probably varies, but what to address that real quick? Just
Sure. So if we're purely doing a fat grafting procedure, we've already done everything else. Let's say if I'm just doing a fat grafting procedure, the incisions are, I mean, they're tiny. They're the size of so at most 0.5 millimeters, maybe 1/8 of an inch, very small incisions. And most of the time we use previous scars.
yeah,
If there are
yeah,
any, if not, we'll try to hide them in the crease. But
yeah,
even if we cannot hide it, it's a very small incision, and patients do go home the same day.
yeah,
Depending on the amount you're fat grafting or locations, because sometimes you have to turn the patient and get the fat from different locations.
sure.
It's about an hour to 2 hour operation. Patients go home the same day. I've definitely had patients do this procedure over a long weekend and then go back to work.
Mhm.
I main restrictions to that is just don't disturb the breast or the graft area we fat grafted to.
No big hugs when
But
you go
this
back to work.
correct. But there's no structural changes. There's nothing that the patient is going to do to tear or rip, like we generally say in surgery, 6 weeks. 6 weeks is the maximal scar strength. That doesn't apply here because there's really no structural changes.
Mhm.
There's so that is an easier procedure to tolerate. The area where we take the fat from feels like a bad bruised for a couple of days, and
Looks like it
as the
too.
right. And as the inflammation goes down, you start to feel better and you don't feel that much pressure in the area. And in general, we space them out 3 to 6 months between the procedures so we can
Okay.
get the area where we took the fat from to enough recovery time. And also in the breast where the fat was placed, we want to make sure that the inflammation and the fat that did not survive is where you see this delayed decrease in volume is like 6 months, 3 months later, because your body cleared out the dead fat cells. Once the fat cells have died, they do not come back. So the body has to clear that out, and then now you know your true deformity again.
Mhm.
Is it a deformity or is it not a deformity? So waiting longer allows me to decrease the amount of operations, because sometimes you go back too early and you may not need to go back
Right.
because the problem wasn't there.
Yeah.
Uh, but if you see the problem early on after the fat grafting, then you know you're gonna have even worse deformity waiting longer. So in
Yeah.
general, that those patients can go back earlier.
Yeah.
So it is an outpatient procedure from that standpoint, but a lot of times it's combined with second stage procedure.
Yeah. This was great information today. I think that the patients who have been so inquisitive about this are going to learn a lot. So, if anybody has any further questions, you can drop it in the comments and we'll look at those and see if we can answer them. I'm going to throw one question at you that I didn't plan to. Just an open-ended question, no right or wrong answer. But what do you think the value is, Dr. Matatov, of patients connecting to patients, good or bad? Real quick.
Good, good,
Mm-hmm.
good. We encourage people to talk to other people, other patients. We also allow through obviously a system or a way to where patients can our prospective patients can talk to previous patients, try to make it as anonymous as possible. But most patients that go through the surgery afterwards are become huge patient advocates. They're like, tell me who I can help. Please call me if I have a patient that want to talk to me. I mean, that's amazing.
I love that too.
That is amazing. And they give it, we don't even ask for their permission. They're like, if they have a patient, please call me. I would like to talk to them. I would like to encourage whatever, or just talk about my experience.
Yeah.
And I tell patients, look, I can talk about the surgery, I can perform the surgery. I don't have any personal experience. I don't have the day-to-day experience
Yeah.
that a patient had in the past. And I learned from when people talk about their experience, I'm like, okay. And it actually helps me because now I'm like, wait a minute, I didn't think about that. I didn't know there was a problem. Just like breast sensation. Nobody thought breast sensation was a problem until the New York article came out. You're like, okay, that is a problem. Not feeling the hug of your loved ones. It doesn't seem like a problem, but all of a sudden it is a problem.
Yeah.
Well, how can we address that?
Yeah.
Or a garment issue, like, oh, this garment doesn't work because, and and then you get all this information, and we ourselves can refine the process. And I think it's very helpful for the patient to hear from another patient that this is doable. You can
Yep.
go through this. Somebody already done it, and there's a process installed in all these practices, and they can guide me through this process. I think it's a huge tool for patients to use, and they should use that if there's a possibility. And I
Yep.
think
Nothing like the lived experience.
correct. And I think sites like yours, or what you do, your foundation is crucial to the breast cancer community. Crucial.
Thanks. I appreciate
Of course.
that. Okay, wait. I have one more. Didn't you just add a new member to your family recently?
Oh boy. Yes.
I had to
Yes,
bring
her
it
name
up.
is Cosmo. Her name is Cosmo.
Who's Cosmo?
Cosmo is our dog. We added a puppy. I know.
You cratered. You cratered. You were one of those dads who cratered. You know what? Enjoy that puppy. We had one for our boys growing up. There's nothing like it.
You're right. You're right. I'm working through some stuff.
Your shoes. Okay, for us, it
Yeah.
was shoes, it was cables, it was actually even the side of the house.
Yeah, she's trying to chew on the couch now. Yeah.
Yeah. Well, welcome to being a, what would you call that? A puppy dad club or whatever. I don't know what it is. Cosmo. I
Yeah.
like that. That's a cool name. Well, okay.
My son came up with that one. Yeah.
Well, enjoy your Cinco de Mayo with him this afternoon. Give my best to the team at Southwest Breast. I thoroughly enjoyed coming to see you guys. And this has been really a great educational session for patients. And I'm just going to say, I hope some other surgeons listen to it too. I always think we all learn from each other. So, Dr. Matatov,
I agree.
from Southwest Breast and Aesthetics in beautiful Scottsdale near Phoenix, Arizona. Thanks for joining us today.
Thank you for having me there.
Absolutely.